Hi, welcome to Habitual Excellence. I'm Mark Graben from Value Capture, and our guest today is joining us from Brazil. He is Carlos Frederico Pinto. Everybody calls him Fred. I call him Fred. So, Fred, welcome to the podcast. How are you?
Hi, Mark. It's a pleasure to be here. I'm very excited about joining this podcast today. Thank you.
Yeah, well, there's so much we can cover and discuss on many levels. Fred is a physician. He's an oncologist, more specifically. He is the CEO at Grupo IOV. They're an oncology group of caregivers. Fred, could you tell us a little bit more about the organization?
Yes, well, we are a 25-year-old organization that I started with my colleagues back here in Brazil, and we serve. We have our own facilities. We have 4 facilities, but we also provide care in hospitals. So we serve 3 different hospitals in comprehensive cancer care, and for whatever you want: surgery and radiation oncology, medical oncology, and support services, social services, physical therapists, whatever.
So you're working as a partner for those organizations. I'm sure you have perspectives on or connections to the leadership of those hospitals. Do you end up collaborating in your improvement efforts?
Yeah. Usually we used to run their cancer system. So what we do is run their system and provide them all different types of cancer care and coordinate care, because the biggest challenge in cancer care today is to provide like a smooth care. If you don't, the cracked care that you see everywhere, go to different places for different doctors, and we try to navigate patients, creating them a smooth flow. That it's the whole idea about it. So we provide this care through all the system. And we've been working with the public healthcare system as well. So Brazil, we have a very confusing healthcare system, but it's not far from US. It's very confusing as the American healthcare system. But we have a public system, and we work for this system as well. And we provide care for those. And for like 3 or almost 4 years, I'm working with the healthcare authority here too, in the city where I live at São José dos Campos, to create a better flow for care. And we're achieving some results that we can talk about it later. But it's very exciting. I like it.
Yeah. So we'll come back and talk about improving flow and reducing waiting times and other things that you've achieved. But just for a little bit of context, as a follow-up, the high-level Brazil healthcare system, is it a mix of private payer insurance and government payment?
Yes, it's a mix of it. But 25% of the population has access only to the public system. They don't have access to care system. We work in both, but most of the money is in the private healthcare system. So it's a very uneven system.
Yeah. So I have seen Fred speak and present at conferences both in the U.S. and in Brazil, and it's been great to hear your perspectives as you've shared in those conferences. And there are white papers and other things that we'll link to in the show notes for the episode. But I wanted to maybe take a step back. If you recall, Fred, do you know what was your very first introduction to lean? If you can give us some context of when you learned about it and why this is something you ended up studying and practicing.
I started my journey in around 2007, 2008, when we were struggling with those accreditation certificates for healthcare. And we were experiencing a bad time because we saw a lot of waste in the process and no real value added to the process that they were introducing at that time. Now they are much better. Now they are doing much better, those accreditation systems like JCI or whatever. So I just Googled waste and I found the Going Lean in Healthcare, the IHI white paper. Fortunately, I got it. Later, I got access from a book that happens to be your book, Lean Hospitals, and started working on that. Unfortunately, I got some friends back in Brazil and in US, and I got a lot of support from John Toussaint, Helen Zach, Kim Barnes, at that time from Theta Care. So I got a chance to learn from these people, to learn from José Ferro, the Lean Institute here in Brazil, and other guys like Flavio Battaglia. And we started this journey, and it's a journey, so it's never-ending journey. And we were working together with the guys in Brazil, and we were working like with some guys in the States as well as the Lean Healthcare Initiative nowadays. So it's a long journey.
Do you remember what the first maybe small experiments were, the first steps you took in trying to apply Lean principles?
It was amazing because we got a huge outcome from this small experiment, and it was working with we were focusing on patient care, and we had a lot of delays in the system, going patient from appointment to chemo treatment. So it's a process. You got early in the morning, blood collect tests for chemo, go to the doctor and wait for the chemo. And sometimes it took like half a day to get to chemo. And we reduced it a lot, but we learned a lot as well, that there was a lot of waste in the system. We did a lot of spaghettis, finding about movement and improved the movement, reduced it dramatically. So it was a great experience. And I figured out that during the years that the first experience is really great because there's a lot of waste in the system, and every time that we apply it in a new organization, we find they can get great results easily because there's a lot of waste around.
So I want to step back to sort of some of the high level advice and recommendations that you give. There's a Lean Global Network white paper that you were a contributor toward. And in there, there are 5 guiding principles, and the first one says, "Don't wait for the CEO." I was wondering if you could sort of share some thoughts around that. That we might say the ideal state is a CEO who is actively leading and driving the transformation. We talked to some of those CEOs here in this podcast, but if we don't have that, why do you say don't wait for the CEO?
Yeah, well, it happens to be that I am the CEO of my organization, so I'm not the right guy to tell you don't wait for the CEO. But actually, the point is that improvement does not depend on the CEO to happen. And CEOs don't have enough time to spend time in approving everything you're trying to change or participating in every stuff. You need to have like some from the CEO, but the problem is yours, and you must work with the problem from yours perspective, not CEO's perspective. And systems, they behave like themselves. So I think that hierarchies are not good for the systems because it has self-organization, and it depends on the people that are really doing the work. So CEOs usually mandate something or order something, and people just turn around every time what they are trying to say. So CEOs need to learn a lot about Lean. And if you're trying to start a new initiative, start it with some approval of your superiors, but don't wait for them. They don't have time to be at the game. But in the beginning, late, they will learn from you, for sure. And we are learning from this white paper because it was an experiment we did, looking around a lot of countries and a lot of organizations, and this is a common behavior of those initiatives that are doing great.
So maybe we can step back and ask you, Fred, about how you operate as the CEO of an oncology group. What I hear you saying is, and I mean I agree with you, is that it's not the role of the CEO to be micromanaging or to be jumping in and solving problems for people. But how do you see the role, or how do you operate in terms of trying to help create a lean culture, creating the environment where people can take ownership of problems and do experiments without running to the CEO for all of the answers?
Well, what happened in my system, in the system that I work in, is that I was the architect of the system. So I had a chance to build a skeleton, a structure to work like a lean system from the scratch. And what happens is that the CEO will not do it. So when I was at this point, I was doing it on daily basis. Nowadays, I have an architect managing the system, and the only stuff is my job nowadays is with them, of course, is go to the huddles I had to be. So we have tired huddles, and I participate in 2 tired huddles, once a week in one and once a week in bi-weekly in other, and participate in Gemba walks. So if I have to go to my organization and discuss, I will be doing it at Gemba. So, and my role at this point is much more like a coach, a mentor, and I spend most of my time mentoring my people than actually taking out decisions from micromanagement. I discuss with my board about the strategic decisions. I take part on some tactical decisions, but at Gamba it's just coaching and no micromanagement at all. I mean, no, that's not. So I spend most of my time at Gamba seeing what's going on and learning from them, because they know what they're doing much better than I know now. Now I'm the kind of guy that I'm very specialized in a lot of things, but I know a little bit of things, not enough anymore of those things.
Yeah.
Especially in oncology, because it's like rocket science for me now. I've lost a lot of new drugs and new technologies that are coming from the bench.
Yeah. So maybe we can drill a little bit deeper into some of those things that you mentioned, the tiered huddles, the Gemba walks. One question that comes up a lot in the context of tiered huddles, people will ask, how do you find the balance between encouraging frontline teams to be addressing issues and working on improvements at their level versus things that need to be escalated to senior leadership? Can you think of an example of something that does get escalated where you have visibility, let's say if it's a systemic issue or something the frontline team can't address?
Yeah. So we created the backbone of our system is the huddle and make problems visible and solve problems, treat problems. So make an A3 about your problem. So that's our backbone. And we work on these 2 pillars all the time. And the system goes like from operation to strategic going this way. So we have huddles trying to solve problems. The point is that some problems there's nothing such a special thing, but it will involve like approvals from certain different insurance company, and we will have to get an appointment with some guy from the insurance company. And this is it's a Gamba, it's a operational problem that we see in the Gamba, but we will need to escalate it to solve it. And it's quite simple to make it. So it goes like, nowadays it goes almost like automatic. So I need to talk to somebody needs to schedule me someone to talk from this insurance company to solve this little issue about approval or whatever. But some problems involves like, and we have this problem a lot. Physicians prescribing drugs that are not standard protocols. So they're not following the standard process of care because patients are not standardized. So we need to adjust. And we have like variation that we accept in the system. So some variation of protocols are acceptable. Some will require interventions. And some of these are just errors, mistakes. And these are problems that are usually escalated when we find a mistake, because we consider it's like a never event. So it's a safety issue, and we go and escalate those. So and it goes from the operational huddle to the doctor's huddles that goes once a week on Tuesdays. So moves straightforward. And we move those on boards, simple boards. So you got like a safety alert that is created, and it must be escalated for a doctor, and goes for a doctor in the huddle. And when those problems get quite common, and we had it like 2 or 3 times a year, we find some bugs in the system or something like that, that the problems becomes repetitive. So we escalate it to a better problem-solving intervention, requiring like system intervention or something like that, IT intervention or whatever.
Yeah. Well, thank you for sharing that example. I think that's a really good illustration of systemic problem to, at the very least, so you have the awareness of it, if not helping others improve that system or supporting them in that. Coming back again to Gemba walks, as opposed, and what advice would you have for people, CEOs, other leaders, of being there physically is one thing, but then like, what are some of the key behaviors that you've found really helpful to facilitate your learning, as you described it when you go to Gemba?
Well, first, be patient.
Yeah.
Because people learning, they have different time for learning, and they have different understanding of problems. So asking question is something that you must learn. What I would say to you, well, if you go to Gemba, be sure that you have a established vision of what you're looking for. And this is a little bit about design of where you're looking. Well, we're looking for a perfect care, for like, I want this in a perfect flow, so let me use my patient's shoes for that. And what we really do is ask patients for do Gembas with us, and provide us some feedback on what he see or what she see, and what we're thinking that we are doing. Because sometimes we're thinking that we're doing a great job for patients and say, oh, I hate this.
Right.
I don't like it. You don't have to do that. It's unnecessary. Don't waste your time with that. Yeah. So go on patient shoes and be patient about what you're asking, and because people will get, especially with me, I'm the CEO. I have new employees that are very embarrassed to having me at Gemba asking him questions, asking her questions. In the first week, well, what I made wrong? What have I done? Because they are not used to that behavior. So be patient. Be very careful about your questions, because the point is about micromanagement. And because you said that before, don't micromanage, and be careful with the questions that you're asking for, not micromanaging.
Yeah.
And create a safe environment for people. Yeah. That's the most important thing. To be open about problems and be safe about discussing, and understand freely that you can make mistakes, and it's normal.
Yeah.
We expect for that.
Yeah. Well, we're all human, doctors included, right? We all are capable of making mistakes. I mean, what I hear you describing, in addition to being patient, is having empathy for people who, as you described, are uncomfortable or just uncertain. Why is the CEO here now? Normally, for better or for worse, I'm left alone, and now Fred is here. I've seen that in a lot of organizations. The first reaction is, oh my gosh, what's wrong? Who's in trouble? But you can build comfort and trust with people, right? So I want to talk more about some of the improvements that you've made in reducing waiting times and improving access to care for cancer treatment. I was wondering if you could maybe kind of give us sort of a verbal case study of some of
Okay.
the tactical lean improvement work that's happened there.
So we started, well, we have a clear vision that is reduce cancer burden. That's our mindset, because everyone is touched by cancer, everyone. So my mother is treating now for cancer, and everyone has a friend, a relative, whatever, that is touched by cancer. And the burden of cancer is terrible. So our mission is to reduce cancer burden by improving the way we deliver care, improving the experience of care, and reducing the cost of it. So we've been doing this for years in our organization, and we're trying to do it in all organizations that we are working with. But in 2018, we started to work. In 2017, we started to work with the public authority in the city to try to improve the flow of the patients. Because once the patient gets into the hospital, it's okay, we can provide good care. But before, we're not there in the primary care units, and they are completely lost about those patients, and they don't know what to do. So we started a project with them. But the cancer project actually started in 2018. But we started other projects with them. But we decided in 2018 to improve cancer care for the whole system, Well, the city is like 2020, 720,000 inhabitants.
Okay. Yep.
So it's a big city. It's not that big, but it's big enough. And we have like 4,000 new patients a year. Half of them going to the private care, half of them going to the public care. And those patients going to the public care don't have good access to it. So we created a system using what we've learned before, considering like tired huddles, standard processes, improving flow, redesigning flow, visual boards. We created a really nice Heijunka board for managing those patients, and we love it. I love this board because it's very visual, it's very illustrative. And we created a leadership hotline, because we're talking about 50 primary care units. So we cannot be in 50 primary care units speaking about cancer. So we created a hotline for those who want to listen and discuss with an oncologist. And we have like about 3,000 calls from the beginning to these days to improve flow, to provide information, to create engagement on patient care. Most of these calls are from nurses. And we were able to improve dramatically the diagnosis of cancer. So we improve it a lot. It's 2 times fold increase the cancer diagnosis in the city. But we also improved the time that patient get from the suspected cancer to cancer care. Like 2/3 of patients now are getting from suspicion to care in less than 60 days. That it's a good number for a public healthcare system, at least in Brazil. So we were able to provide, using tired huddles, standard of care, regular standards of access and care, visual management, and leadership access at Gamba, because the way we found it was a hotline. We cannot be there all the time, to improve access to care. And most of it, actually this week we got one more information that it's a sad information. In Brazil, cancer diagnosis was reduced by 77% in 2020 due pandemic. So it's not just COVID, the killer in Brazil now. We're dying with cancer now, because if we are reducing 70% of our diagnosis, most people will die, will not be cured, even with good care now. And we found that in the city here, the reduction was only 20%. That's not good, but it's not bad at all. I mean, so we were able to sustain it even in pandemic days. And we are happy with that, because our patients are getting care and are getting their diagnosis. So that's the perspective. Reduced cancer burden, and we're accomplishing it So that's why we're very, very happy with these results right now.
Yeah, well, that's great. And I hear you describing two major sections of the value stream, if you will. One is the very early stage of diagnosing, detecting the cancer sooner than later. And then once it's diagnosed, getting into treatment sooner as opposed to later. Yeah.
Yeah.
And imagine that first part of the value stream of even detecting the cancer seems like a very broad systemic problem of, do people have access to physicians? Do they know what warning signs to look out for to detect things early? And I can see where during the pandemic, if people aren't going to the doctor because they have to stay at home or they're afraid to be around other people, that leads to the lower detection, right?
Yeah. Let's take one simple example that is the easiest example at all. It's the prostate cancer. Well, we have a blood test that it's the blood test for prostate cancer, PSA, and you get it higher, you have high suspicion. You get it lower, you low suspicion. Mm-hmm. The point is that those exams were holding in the labs, and nobody was looking at that until the patient come to the appointment. So you have a huge inventory of blood tests waiting for someone to look at it, and you have no alert signs because the lab was not prepared to respond for this. So what we did was that, well, every blood test that you got a PSA, you will send to me. Mm-hmm. And I will decide what will happen with the patient. And we decided that if you got PSA for more than 10, that the cutoff that we decided, we will put this patient, we will bring it up front and make it out of the line and take it from in advance. Mm-hmm. And we move it like so. What happens is that we have like 3,000 patients doing PSA per year. And we have a few of them that are really dangerous. But we will look for those with no regular manner, with no standardization, with no standard. And what we did, we just created a standard for that. As we did for mammograms, and then for pap smears, and for colonoscopy. and we broke the problem into parts and created the same behavior for each different disease. And from this same behavior, from this same standard, we created this and designed a flow for the patients. So looks very complex, but it's not. Complex is when you look at the whole, but when you break it into parts, you can make it more touchable and more understandable, and you can name the person that you're looking at. Yeah. So that's the real difference.
Yeah. So in generally speaking, how much of the improvement comes from projects, as you had mentioned projects earlier, versus daily improvement through huddles and A3s and other methods?
Well, I don't know how to answer that because I see working at IOV, we usually do big improvements when we have to change some new stuff, but at IOV we're doing it like for 12 years, so people are used to do it, and they open A3s, and I don't have a count anymore for how many improvements are going on as A3s, and we call every A3 as a small project at IOV. So, but going to the healthcare authority here, that we're working them with a model line in a basic care unit, a primary care unit, creating a model line for them to learn and to understand. I can say that we have like 3 going on right now, 4 A3s going on right now, and every day small improvements gets on the board, on the huddle. Every day they're improving the system. So we are trying to count it, but it's not countable anymore. Because people, when people understand that they can improve the system by their own, and they get possession of problem solving in the system, when they have support from the huddle and possession of problem solving capabilities, they will do it. So every day that they're discussing, they have new suggestions and new improvements. Some of them we have to make it like an A3 because it's not easy, and those will probably be escalated. But on daily basis, they are doing it every day.
Yeah. So one other thing I wanted to explore before we wrap up, when it comes to the everyday, is this idea of having a lean culture. And I wanted to ask you more specifically, what does the phrase "respect every individual" mean to you, and how do you demonstrate that or encourage that in like very specific ways?
So I used to tell to be very very emphatic about it. Yes. So making me wait is not respecting me. Asking me 3 times the same stuff is not respecting me. So respect every individual is, well, besides being just minimally polite, because it's not very usual with doctors, and we see a lot of this these days. But leaders try to solve problems by just giving answers, and this is not respectful because they don't know what's going on. So for us at IOV, respect for people is, tell me what's your problem and how can I help you to improve the work you're doing, and how can I help you to make your work more valuable for you and for your patient, for our patient. Because and we see that in the primary care unit that we're working, because those guys there, they understand clearly what's value, what's respect, and they did it before we were there. So people know that. They know when they are feeling not respected, and leaders are not good in respecting others. They're good in ordering new stuff and making new rules that won't work as usual. So try not to create rules that you are not understanding why you're creating. Try to understand why you need it, and be patient.
It's always good to be reminded of that again. One other thing that came out from some of the materials you had shared with me, presentations that you've done, I was really happy to see mentions of error proofing. Go back to the Toyota production system, just in time or flow. Then there's the second pillar of whether we use the word Jidoka or built-in quality or error proofing. What are some examples that come to mind for you of error proofing, and why is that so important in the work that you do?
Yeah. Well, one of our that's a tricky question, because I'm thinking about it, and one thing that we believe is error proofing, and it's not clear that it is a checklist. A checklist is just another job that you have to do because your boss told you have to. So most people think that when they're creating a checklist, they're creating some kind of error proofing. And well, it was proven. You can prove that it works, and you can prove that in some organizations you don't need it. So error proofing for us now is to create the perfect environment at the point of care. So what do I mean with that? Reduce the risk of making mistakes by creating the perfect environment. So if I'm gonna make like vaccinate a patient, I need to have the perfect environment. And what I mean a perfect environment is having in front of me only the material I need, the stuff that I will use. And so we are trying to make it like creating small packs or small kits of work, and pack it in a small container or whatever to make it safer to work. So it's not a perfect Jidoka, it's not a perfect Pokayoki, but it works quite well, and it's good enough for us at this point. We have some perfect ones like with equipment, whatever, but when you're confronting a patient and in a ward or in a treatment room or an appointment room, this people are trying to be empathic and not being automatic. So we try to just create a perfect environment and try to use it the best way we can make it. So it's not perfect error proofing, but it's an empathic way to make things work.
Yeah. Yeah, I like the way you describe that. I mean, the ideal state of a perfect environment where it would be completely impossible to make an error like that, that's a really high bar. I agree with you. I mean, I use checklists in some of my own work related to podcasts or webinars. What I do is never a matter of life and death, but checklists are only as good as our willingness to follow them. I've gotten in trouble where I get a little bit arrogant. I'm like, I don't need the checklist anymore. And then that just invites error.
Yeah. So, but they're good. They're good tools. They work quite well.
Yeah.
But in healthcare, it's not. I mean, in the care environment, sometimes it's just another job, and you're overloaded of tasks. And here another paper for me to fill in. I won't do it, or they just do it like check, and it's not respectful. It's about respecting people. So you're just creating more work and not reducing the work of burden.
Yeah, and I think there's a difference between the top-down mandated checklist versus something physicians, the people using the checklist when they're involved in developing the checklist, that sense of ownership is incredibly important.
What we're experiencing with the guys at those model line we're working at the primary care unit, and what we are trying to make them understand is that, okay, you can introduce a checklist, but instead of doing a checklist, you can create a perfect environment with the checklist out of the process and provide into the process the perfect environment. So you create a checklist out of the process, but not make me feel that checklist during my patient connection. And if you can convert this checklist into visual tools, much better. So you will reduce the amount of stuff that you have to deal with just with visuals. And we are trying to work with that. So we create visuals that try to eliminate steps inside the checklist.
Yeah. Well, that's great. Well, Fred, thank you so much for sharing all of your perspectives here today. Is there, I'll leave it to you, is there any final thought that you might want to share with the listeners?
It's a pleasure to be here. I'm really, really excited because, I mean, I had a chance to learn from your book. Thank you for sharing that knowledge. And I have my own book published in Portuguese as well. And people come to me and say to me what I'm saying to you. Thank you, because it was very helpful. So thank you for inviting me. It's a really, really, I'm really honored to be talking to you today.
Well, it's an honor to talk to you because you're putting that book and everything else you've learned from other people to great use for the benefit of a lot of people. So, Fred, thank you for all of that, and thank you for joining us today.
Thank you, Mike. See you, Mark. See you soon. Hope you see you back in Brazil.
I very much look forward to that.
Yeah, great.